So I'm going to jump off of the previous talk here and really talk about family care plan and education for families and ourselves as we move forward in 2024. And I have no disclosures. So I do want to make sure we zoom through the history of the family care plan, which is updated terminology for the plan of safe care. You're going to see it referred to throughout this talk as plan of safe care to align with our current documentation. I want everyone to be aware that as of January of next year, the plan will be that all of the documentation says family care plan. I also want to go through a couple of other things that have happened at UVM Medical Center in our attempts to decrease bias in testing, and we've covered breastfeeding. And then really the big take home is how to identify resources to support these conversations, to educate ourselves and to empower families. So here's stuff I hear all the time. I've never heard of the plan of safe care. I don't know where to find the policies around substance use and pregnancy in Vermont. Where do I even go? How common is substance use in pregnancy anyway? And I don't even know what to do with that plan of safe care. So let's start there. The Vermont Family Care Plan or Plan of Safe Care. So remembering that our goal is to support families across a continuum, and I love this because it talks about supporting people pre-pregnancy, so prevention models, and our health department colleagues coming in here, prenatal, so all of us that are working in the space of taking care of pregnant individuals. And then there's this big line that happens where the baby is born, and then we have a new team that moves in, and we have the infant team, and then we have all of our community supports, hopefully involving and supporting the entire family. So we are all on the same page. We need to know the definitions of CARA and CAPTA and where the plan of safe care came from. So the Child Abuse Prevention and Treatment Act is a giant piece of legislation, of which CARA, which is the Comprehension Addiction and Recovery Act, is part of that. Now, CAPTA covers many other areas and is a very important source of funding to states. In this case, the CARA amendment had a goal to address the needs of infants affected by substance use. And affected by is underlined here because that's where each state has chosen different ways to interpret that language. This also applies to infants affected by fetal alcohol spectrum disorder. So the requirements of this legislation amendment is, number one, we have to identify infants affected by substance use, withdrawal, or FASD. Healthcare providers need to notify Child Protective Services in their state. There needed to be the development of the plan of safe care, and then the state CPS services had to report data annually to the Children's Bureau as part of their overall CAPTA report, which is, again, a large document. In Vermont, our goals were different. So we wanted to continue to support pregnant individuals, making sure they continue to seek substance use care and avoid legislation that was punitive. That is not the tack that many states took. We wanted to support existing relationships between providers and support people and pregnant people. We wanted to make sure referrals to community resources were identified. And again, that includes nurse home visiting services, and then encouraging communication. And really the warm handoff from the pregnancy provider team to the infant's primary care provider, and hopefully the parenting people's primary care providers to continue to strengthen family-centered care. So the way we went about this in Vermont, we first identify newborns via conversations, right? So prenatal screening or reported use by pregnant individuals, or the known use and prescription of medications that healthcare providers are administering to pregnant individuals. After birth, say we don't know about prenatal exposure, we're looking for clinical signs and symptoms of exposure or withdrawal. People call this neonatal abstinence syndrome, which is a much larger term. Neonatal opioid withdrawal syndrome would be more specific to opioids. In the case of FASD, we're looking for a constellation of physical findings after birth. That second requirement to notify Child Protective Services. So each state needed to define and set up their own system. Now, some states have CPS involved for every time there's substance use in pregnancy, and that's prescribed or non-prescribed, street or illegal. It's very punitive in many states. In this state, we have two pathways. We have a reporting pathway, which has always been there, and that really, again, identifies child safety concerns. That's through the centralized intake team. And in that case, the Department of Children and Families works together to develop care planning with the family and other providers and supports. We set up another pathway called the CAPTA notification, or it used to be called DCF notification pathway, in the setting of no child safety concerns. And this is all de-identified with no parent or infant information. And this is done by hospital staff along with a plan of safe care document and sent to the infant's primary care provider. So I think it's really important to know the difference between the two. So the use of substances in the third trimester, more specifically the last 30 days of pregnancy, which is when we have a DCF statute that allows us to open an assessment if needed. This would again be non-prescribed or misuse of prescribed medications or suspected fetal alcohol spectrum disorder at the time of birth. That is a DCF report through the identified call. A CAPTA notification is when people are appropriately using prescribed medications. And I think this makes sense to us in Vermont, that if you're prescribed medications for opioid use disorder or chronic pain management medications or benzodiazepines for anxiety, that doesn't make sense that you would call DCF for an investigation when a doctor is prescribing that. We also opted to make cannabis use not a reportable condition unless there are other issues. So this would also go through CAPTA notification pathway because the federal government requires us to continue to track that use. Okay, so here we are at the plan of safe care. In Vermont, this is created with the pregnant individual and other caregivers. It needs to be done by birth hospital discharge. Ideally, it's done prenatally. It's a listing of supports and strengths, as well as needed referrals and needed supports. It is shared with the parent and the infant's PCP, and that is all who gets this unless the family chooses to hand a copy to somebody else. And this is not sent to DCF unless they're already involved for other reasons. This is what the Vermont Plan of Safe Care looks like. So there's information about the family. There is an indication box here on the top so that the primary care provider is aware of what medications were triggering the Plan of Safe Care. There is a whole list of different supports and referrals. We broke them into infant supports, such as home health visiting, early intervention, help me grow. And then for maternal or family supports, there are many more here. And again, things like smoking cessation, safe sleep, recovery supports, all of those things are here. And then we do invite the family to sign saying that they are have a copy and they understand it will be shared. They do not have to. They can decline to participate entirely, and that's fine. That doesn't trigger any sort of reporting mechanism. As part of what I talked about, the CAPTA notification form, I really feel like it's important for everyone to understand that this literally has the 4 things we need to track for the Children's Bureau. We need to track substance exposure. We need to track that a plan of safe care was done and whether there were already treatment services or new referrals made. This is literally sent as an aggregate number to the Children's Bureau once a year. There's no information about people. There's no information about regions of the state. It's a very low bar. And so we really carefully made sure we were only collecting things we absolutely needed to. And again, this has an identifier on the bottom so that we don't get multiple notifications from the same hospital on the same patient, but it does not have any like date of birth, names, medical records, any of that. So the data reporting, this is exactly what it would look like. So again, aggregate data. And what you can see is each of the last several years, we are collecting the number of these secure faxes that are sent over. In 2023, we received 153 notifications. And then just to show people what the CAPTA notifications were for, what we can see is most of the notifications, about 28% last year, were for medications for opioid use disorder and cannabis use. So we have to collect those treated for with benzodiazepines and opioids for chronic pain, and they have really been stable at 1% or less of our population. So what happens with the plan of safe care after discharge is also a good question. And really, this should be going to the infant's primary care office as part of discharge materials. And that should be kind of the warm handoff to follow up on new referrals. And the family should also be empowered to follow up on these new referrals, and make sure that if they were referred to home visiting, that made its way through, or Help Me Grow. There's an entire website devoted that will need to be fully updated to the Plan A Safe Care. It has lots of frequently asked questions, and there is a handout just for families here. This is what one of the frequently asked questions looks like. So I'm going to zoom through very quickly just other ways to decrease bias, and I know this has come up a few times, so I just want to remind people that substance use is extraordinarily common, and caffeine isn't even on here, but alcohol use in pregnancy is 12%. Cannabis is 8%. Tobacco use is 8%. Non-cannabis illicit drug use is about 3.5%. And if you look just at opioids, it's less than 1%. And this is updated from 2022. In Vermont, in pregnancy, we see a little bit higher rates of use of alcohol, cannabis, and tobacco products. However, I will say, if you look in the second comment column, we can see that many people stop using when they find out they're pregnant. So 71% of pregnant individuals say they used alcohol prior to pregnancy, and only 11% during pregnancy. So it's a good reminder that we know how to have these conversations with people about decreasing substance use. Now, as has been kind of really said several times, I just want to remind people that we should be screening for substance use. We have some of the highest rates in the entire country, but that's with a tool. There's a paper tool right here, because we can use, just like in all other settings, screening and brief intervention, referral to treatment mechanisms to get people the help they need if they have signs of a substance use disorder. And you've seen this a few times too, but remember, substance use screening does not equal drug testing. So what we really wanted to do at UVM is move towards something that would decrease bias in testing of parents and infants. And so universal umbilical cord holding, not testing, really the idea is to eliminate testing bias, because we would only send testing if there were signs and symptoms concerning for withdrawal that we didn't know about. It does reduce the urgency because we have up to 5 days to send that cord for testing if there's unexpected or confusing withdrawal symptoms. It's something that can be collected from all deliveries, unlike urine and meconium that's difficult to collect. And for us, we have developed a pathway that makes it faster and more reliable, as it's confirmed testing, and it reduces false positives seen in urine sample. We can get a turnaround in roughly 2 days, which is faster than meconium. So when may testing be indicated in moms is always important, and we are drawing the line at less than 1 prenatal visit, or someone that presents with unexplained signs and symptoms of intoxication or withdrawal may be indicated, because that may change their clinical management. In the case where that is indicated, you need to obtain informed verbal consent and document this, as well as the reason for medical necessity, and then order the drug testing. If there are unexpected positives, you must confirm those, because there are many limitations to urine drugs testing, including false positives and negatives. In infants, there are very few cases, but there are cases where testing may be indicated. So again, unexplained signs and symptoms concerning for withdrawal, and in those cases where maternal testing may have been indicated but not able to be performed. And then the process here, again, informed verbal consent, documentation, ordering the test. Now, again, if we needed something urgently, like let's say in the worst case scenario, an infant was seizing and there was concern it may be substance withdrawal, that would be the one time that maybe urine would be a faster test to obtain. And importantly, routine care and monitoring while waiting for results to return. So storage of a cord is not requiring consent. It is collected from every delivery and held in the lab, similar to the way placentas are held, and discarded at 5 days. We have a handout for families, and they certainly could decline that if they felt like that was in their purview. Testing does require consent. It needs to be documented. And at that point, a piece of the sample that was held is sent away to Champlain Toxicology for testing. And then again, there's always going to be questions about what if we don't get consent? What if they decline consent? And at the end of the day, if you think there's going to be harm, clinically, the infant is at risk, this is when you should get consultation with Child Protective Services. All right, we talked about the breastfeeding guideline, and I just wanted to put the 6 important points here. And then, oh, I can't see my time. How am I doing on time, guys? So supporting and empowering families. I'm going to go fast. Okay. So here is the umbilical cord storage handout. And again, anyone that wants more information and to see this is just so important, because if a family member has a question, it shouldn't be at the level of the person in the room to have to try to explain this. So this is a handout that can be given to families if they have questions. Similarly, you've already seen this, but this is the breastfeeding handout that's going to be available to everyone to take home and to see in the hospital, so that it really standardizes how we talk about alcohol use in breastfeeding, cannabis use in breastfeeding, and any of the other non-prescribed substances. We also, a couple of years ago, put together a parent preparation video, and you can find this on our website. It's a really nice way to introduce what will happen when you come to the hospital for infants, and really, giving people the information about, yes, you would stay for 96 hours, what kind of things will happen, how you care for your infant that we have rooming in. So it's just a really nice short video about expectations. And then Our Care Notebook, many people may have been familiar with the Our Care Notebook. It used to be handed out in kind of a much bigger binder, and we have made this available online for printing. You can print a page or the whole booklet. And again, we can send hard copies if you would like to have the entire edition. This is the 4th edition, and certainly will continue to be updated over time. But this is an example of a handout for families that's in here. This talks about the Eat, Sleep, Console care tool. And really, again, there are areas in this care notebook around pregnancy, the hospital stay, after the hospital stay, and other resources. Also, as I mentioned, the Vermont Plan of Safe Care, there's a handout for families. And I think importantly, there's a really nice line here about, will the hospital provide information about me or my newborn to DCF? And that answers the questions that many families have. I also want to bring everyone's attention to other Vermont-based resources. So the One More Conversation campaign, there's parent and patient education materials on different substances. There's also a provider toolkit to help with having conversations. This is the provider handout, and this is one of the parent handouts. And it's a nice place to get information, but also links you to things like 211, Vermont Help Link, and other Vermont-based resources. So Help Me Grow 211, Support Delivered, One More Conversation, Strong Families Vermont, Vermont HelpLink. We are really blessed in this state to have many different resources available, and using Help Me Grow can get most people to any of these resources. So it's an easy way to connect families. If you don't know the answer, Help Me Grow likely will. So I want to encourage everyone to support families, and that the more we can get pregnant people participating in local teams to coordinate services, the more that we can work on shared language, releases signed between providers, so we can give the best care and really be on the same page with how we talk to families. We should be offering referrals for starting nurse home visiting during pregnancy and continuing after the infant is born as a standard of care, not an opt-in. It should be an opt-out. And we really want to educate families on what to expect in the hospital and include the plan of safe care, family care plan as part of it, so it's not a surprise. So I always want our take-home points to include that we should support pregnant people to decrease nicotine, alcohol, cannabis, and other substance use. We should be doing that in an unbiased as possible, non-judgmental way, and make sure that we know how to get people that are identifying with substance use disorder into appropriate treatment. And then again, just a reminder, medications for opioid use disorder is the best treatment for OUD and is safe for both the pregnant person and the infant. They should not be weaned off or stopped without consultation with a medical provider, as that can be dangerous for both. Vermont interprets the federal laws in a different way. So CARA and CAPTA mean very different things in very different states. We really want to encourage people to engage in treatment. And there's lots of resources for yourself and your patients out there. So next steps over the next year or so, collecting feedback from all of you on the strengths and areas of improvement on the plan of safe care workflow, updating the materials to family care plan language to decrease stigma, continue our partnerships with DCF to improve shared expectations, language, and processes, and expand our focus to other substances. And I will take questions if I have time. Oh, I went over. Someone should have yelled at me.
Hi, Michelle. It's Brina again. This is not a question. This is a shout out to the work that you have done in this state, in this space. Michelle Shepard. I follow this story nationally a bit from my old days in public health, and it was kind of a doozer, and it brought up a lot, and you have managed it with such grace, and it's been so patient-centered and just really, really showing up for families the way we intend to in Vermont. And just seeing it all put together again this morning gave me goosebumps. Thank you, Michelle.
Oh, good. I'm a fast talker. I'm glad I had enough time to get through all of that. I'm also happy if people wanted to see the flow sheets of that we developed around reports to the Department of Children and Families. That's available on the Family Services Division Plan of Safe Care website, but I'm also happy to go through it for anyone that wanted more information on how we came about those guidelines.